I'm now very, very excited to introduce to you Dr. Sanjeev Arora, who's Distinguished Professor of Medicine in the Department of Internal Medicine at the University of New Mexico. Now, it turns out, as you'll learn, that Dr. Arora is actually trained as a gastroenterologist, so his day-to-day patient care is a little different from those whom you've heard from before, but he has developed a methodology that has just made a tremendous contribution to primary care in a number of settings, both in the United States and across the globe. He's going to talk to you about Project ECHO today. You're going to hear that in more depth and hear kind of a case study from a health center in one of the breakout sessions. But with no further ado and great happiness, let me just give the microphone and the podium to Dr. Arora. Thank you.
Thank you, Jonathan, for this introduction. I did something really stupid 5 minutes, 10 minutes ago. I'm a gastroenterologist. I should know. I should drink coffee. I actually inhaled a little bit. And that wasn't a smart thing to do. So ECHO stands for Extension for Community Health Outcomes. Our mission is to democratize medical knowledge and get best practice care to underserved people all over the world with a goal to touch the lives of 1 billion people by 2025. On the bottom of the slide, you'll see all our funding agency, Robert Wood Johnson Foundation, GE, Helmsley Trust, and federal government, state governments, HRSA, and all other federal agencies support us. The key strategy to get to 1 billion people is to move knowledge instead of moving patients. The project started for one disease, hepatitis C. It now is being used for 57 different disease areas in 19 countries, but the story of hepatitis C will be illustrative. There are 170 million people worldwide with it. In New Mexico, there were 28,000 patients who had been diagnosed. 2,300 prisoners had been diagnosed, and less than 5% of them had been treated. I was running this hepatitis C clinic at the University of New Mexico, and there was an 8-month wait to see me. People were driving hundreds of miles, making 12 to 18 trips while they were getting a chemotherapy-like regimen of weekly injections of interferon, and not a single primary care doctor. We have about 3,000 clinicians in New Mexico. Not a single primary care doctor was treating hepatitis C because it was very toxic, the treatment. It was chemotherapy with these injections causing neutropenia, depression. So we developed ECHO with 2 goals. We wanted to safely and effectively treat hepatitis C everywhere in New Mexico. And we knew if we could do that, then we could manage HIV in Africa. We could manage tuberculosis in India. We could do many, many complex things. ECHO is based on 4 key ideas. The first is to use technology to leverage scarce resources. In this case, I needed a psychiatrist, a pharmacist, and a GI or liver specialist like myself. Second key idea is to share best practices. So what we did is we created 21 centers of excellence for treating hepatitis C in New Mexico. 16 were in federally qualified health centers, such as Margaret described, and 5 were in the prison system. Each of these centers of excellence was run by a nurse practitioner, a physician assistant, or a family doctor. What is best practice in medicine? It wasn't just a guideline. You couldn't just spread a guideline. You could give it to them, but there was a lot of input variation. It was very different from what Deming had described in Toyota, where every car was the same. Here, every patient was different by age, by sex, by body weight, by rich, poverty, educated, not educated, social support, no social support. The guideline had to be modified to deliver best practice for each individual patient. So we said, okay, how do we scale this best practice? And that brought us to the third idea of case-based learning. How are we going to make a nurse practitioner as good as a multidisciplinary team of professors at the university? We said we would train them the same way how I, during my fellowship in Boston, got trained. I would see a patient, present to my professor, see a patient, present to my professor. And I did this continuously for 2 years, after which they started calling me a gastroenterologist. I had gotten converted from a novice to an expert. We said we would do the same with these primary care clinicians and use the web to monitor outcomes. So what we do is we train these physicians, mid-levels, we train them to use our software, and then we conduct these tele-echo clinics called knowledge networks. This is a knowledge network in action. In 2003, I started this weekly clinic on Wednesday from 3 to 5. All 21 of our sites would join us on an interactive video network. First, in the big box is a liver specialist, a psychiatrist, and a pharmacist. On the top right is Deb Newman from Espanola. She would present a patient of hepatitis C to us. I needed 20 pieces of information. She'd give me that in 5 minutes. We would discuss the case, and then we would go to the Department of Health in Las Cruces. We'd go to Las Vegas, New Mexico. Over the course of 2 hours, 1 hour, 45 minutes, we would discuss about 10 cases from everyone, learning from each other, and we would give them a 15-minute lecture on some aspect of hepatitis C we wanted to train them. As we expected, these primary care clinicians were very smart clinicians. They became experts. Over the course of a year, they became great experts through the process of listening to our advice, our lectures, but mostly learning from each other. They would bring one patient every week to the network and learn on 10. They could learn on 300-400 in a year, but mostly they learn by doing. How many of you have taught your son or daughter to drive a car? Can you raise your hand? If I told you you could train them by giving them a book on how to drive a car, giving them lectures on how to drive a car, who would give them the keys to the car? So that was the challenge that we were overcoming. So the reason why ECHO worked was they were learning by doing. We call it iterative guided practice, and we collect data. We've done 600 such clinics, started 21 others in New Mexico, provided 79,000 hours of CME credit in New Mexico alone. Worldwide, we have provided millions of hours of CME credit. First published this in Academic Medicine in 2007. We knew that a primary care clinician would never treat hepatitis C with a chemotherapy-like regimen unless they had a lot of self-efficacy. So we studied that, published this in September 2010. Scale here is 1, I have no skill. 7, I'm an expert who can teach others. What's your ability to identify candidates for treatment? Goes from 2.8 to 5.6 in 12 months. Ability to treat hepatitis C and manage side effects goes from 2 to 5.2. Ability to manage psychiatric comorbidities, 2.6 to 5.1. This was critical. If you didn't manage behavioral health in an integrated way, you could not get good cures for hepatitis C. But question number 5, what we call our force multiplier question. We asked them, can you become a local consultant now in your area? 2.4 to 5.6. So 3 things started happening. First, they treated their own patients. Then they treated the patients of their partners in practice. But last, everybody in the community started going to them. And when Community Health Center, Inc. replicated Project ECHO, I've heard exactly the same thing is happening there, that basically everybody in the community started going to this nurse practitioner to get their hepatitis C treatment. Overall competence went from 2.8 to 5.5. We knew patients were benefiting because over the course of 18 months, the wait in my clinic fell from 8 months to 2 weeks. But we wanted to know, do primary care clinicians benefit? 97, 94, 98% of these primary care clinicians told us that they benefited from this enhanced knowledge, being well-informed and achieving competence. We wanted to ask the question, has it diminished my professional isolation? 4.3 out of 5. Enhanced my professional satisfaction? 4.8 out of 5. Benefit to my clinic? 4.9. Expands access? 4.9. The next question is particularly worrisome for me. We asked doctors in the United States, is specialty access an important problem for you? 4.9 out of 5. In a country where we have twice the number of specialists than any other country in the world, 50 times more than sub-Saharan Africa, and our doctors cannot find specialty access. So we have hypothesized 6 billion people in the world don't have access to the right knowledge at the right place at the right time. Therefore, it is impossible to get the right care at the right place at the right time, and that's the problem we're trying to solve in our project. But of course, it's not good enough that doctors are having a great time. You know, the issue is really, can they do as good a job as a university multidisciplinary team? We studied that and published this in the New England Journal of Medicine in June of 2011. We showed that the cure rate for genotype 1 was the same, 50, 46, 70, 71, and we were able to improve access to minorities. 68% of our ECHO patients were minorities versus 49% university. The more important thing which we discuss in the discussion section of this paper says that the cure rates for hepatitis C were actually higher than when specialists were treating hepatitis C in the United States. And I'm sure Community Health Center, Inc. is exactly finding the same thing in their hepatitis C ECHO. The reason is when you treat a patient close to their home in a culturally appropriate setting by doctors whom they know and trust, and when you integrate behavioral health into the care can be better. It's not just as good as a specialist. In fact, at the same time, with exactly the same protocol, specialists were getting 34% in the private practice settings in the US, and the VA was getting only a 20% cure rate because their patients were far away living in rural areas. After hepatitis C was successful, we described these criteria. If the disease is common, management is complex, new treatments are coming, high societal impact, serious outcomes of untreated disease, and if you have effective treatment, you could use this model. We use the Pareto's principle. So when we go to a different country, we're not trying to do echo in multiple sclerosis. We take the top 20 diseases in that country, and we do echo for those diseases by providing the same level of care at a community health center as the university by cutting horizontally. This is the goal of echo, force multiplier. This is a US Department of Defense term. We have redefined it in healthcare as a logarithmic improvement in capacity to deliver best practice, 10 times, 100 times more. That's what you need if you're going to really make a big difference in the world. These are all the echo projects we have going on in New Mexico right now: hepatitis C, rheumatology, HIV, complex care, osteoporosis and bone health, endocrinology, diabetes. I want to mention a couple of things. We started echo just to treat diseases like TB, et cetera, but then we signed a partnership with Institute for Healthcare Improvement to use the echo model for quality improvement. Community Health Center, Inc. led the way in that. Not teaching how to do a disease, teaching primary care practices how to improve healthcare systems. We are currently in the country of Georgia in partnership with the US government to eliminate hepatitis C there. We've treated 30,000 patients in 1 year for hepatitis C. But the next echo we are starting there is an infection control echo. Because they checked their dentist offices and found 62% of dentists had hepatitis C virus on their equipment, basically. So treating alone wouldn't do the trick. So a lot of our efforts now are going to be in the health system, scaling best practices to strengthen health systems. And I'll tell you more about that. So we knew that hepatitis C doctors were really happy. But then now we have 22 different disease areas. So we know, was this working in other areas? So we asked them. These are less than 100 clinicians, about 100 clinicians. One strongly agree, one strongly disagree, 5 strongly agree. Are you learning best practice? This is now in 22 disease area. 4.68, connected with peers, 4.55, learn with guidance, 4.73, develop my expertise, 4.48. So it was occurring across the 22 disease areas. Benefits patients, 4.45, receive best practice, 4.45. The third question is critical. It benefits the patients whom I do not co-manage with echo specialists. So the purpose is to teach them how to fish, not just giving them fish repeatedly. Make them independent of us so they need us less and less with time so we can go and train other clinicians. The fundamental problem you're trying to solve here is because medical knowledge is increasing exponentially, but a learning ability of a primary care clinician is only going up slowly with time if you're generous. Some say with aging, our learning ability goes down. This creates several problems. The doctor cannot keep in touch with all the knowledge that's exploding. But a bigger problem is that this exponential growth in knowledge because of computing science and genetics and molecular biology will worsen disparities if your knowledge distribution methodology in the world is linear, which it currently is. So you need a logarithmic way to spread this knowledge if you're really going to reduce disparities. The last part, I want to talk about something already mentioned. Chronic disease management is a team sport. If we just train doctors in echo, it will not work, basically. We have to train, in echo, we train community health workers, medical assistants, nurses, because they need to be trained first on the diseases, but then they need to be trained how to work together in a team. They don't know how to work together in a team as good as Margaret Flinter's and Darren Anderson's people know how to do. That is another best practice which has to be trained on. So we have 5 such community health worker training programs. We've trained 150 diabetes community health worker specialists, 125 community addiction recovery specialists. We've trained more than 400 community health workers in the prison. Our specific version, ECHO's version of a community health worker is a specialist, but not in treating disease. He's a specialist patient education and support worker. That's his role, her role, to work in a team. What does it look like? We give them 3 days of on-site training. We give them their webcams. They go home, join every week on an echo clinic, present cases, learn about all these things listed on the slide, diet, exercise, etc. So the potential benefits of the echo model to a health system are improved quality, safety, rapid learning, reducing variation, improving access for underserved patients, workforce training, force multiplier effects, improving professional satisfaction, cost-effective care. The VA system uses spends $1.2 billion in transporting patients from rural clinics to VA hospitals. We want to integrate public health. But the frame shift we have to make all over the world, this is fundamental, is the role of a super specialist like me has to change. My role is not to just help those people who come to see me, but to strengthen the health system and democratize my knowledge, because there is no solution to this world's health problems through specialists seeing patients. It has to be embedded in primary care. Therefore, the role of a specialist should be to move the knowledge and mentor primary care clinicians, and that will create a better world for us, basically. This is a map of New Mexico. Albuquerque, this is our hepatitis C program in New Mexico. These are the 400 points of contact we have in New Mexico. The idea being in each town, Carlsbad, we have one expert in rheumatology, HIV, substance use disorders, hepatitis C, etc. So that people don't have to travel. We have an effective triage system. You only come to the university if you need the university. You don't travel 250 miles to be told, hey, you really didn't need to come here. You've got osteoarthritis, just take some ibuprofen. This happens a lot in our health system. These are all the universities in the United States that have replicated ECHO. We have about 60 of them. So we have one University of Washington, Oregon, Nevada, UC Davis, UCSF, the Utah, Nevada, Colorado, University of Chicago, Harvard, Beth Israel Deaconess Community Health Center, Inc. You can see them on the top right, Johns Hopkins, and many, many, MD Anderson, Texas, and about 60 of them. This is our VA ECHO program, 9 university hubs connected to 600 clinics for 39 different disease areas. This is our US Department of Defense ECHO. We have ECHOs in Belgium, in Germany, in Italy, Japan, everywhere the troops are. This is the use of ECHO to strengthen the health system. It's got good health and wellness in Indian country. 22 Indian tribes, our partnership with the Center of Disease Control to improve health in these Native American communities. This is our partnership again with the US government in the PEPFAR program. In Namibia, only out of 120,000 HIV patients, only 60,000 are getting treatment. This is our ECHO in Namibia, where we are trying to get all the other 120,000, the rest 60,000 on treatment for HIV. These are all the rural hospitals. This is Windhoek, where the expert team is sitting, mentoring them. This is one rural hospital where many, many clinicians, every week this goes on. I invite you to join one of these. If you have an interest, drop me an email and we'll connect you. All you need to, you'll do it from your office. You don't have to move. Just click on a link and you'll be a part of it. This is our program in Vietnam for multi-drug resistant tuberculosis. This is Hanoi, Dr. Noon, the expert. Where are we in the world? We are 19 countries now. As I said, 103 university-like settings. Going to be in Cameroon, Ivory Coast, Kenya has launched. Kazakhstan, Kyrgyzstan have already launched. Tanzania, Uganda. A lot of these people, of course, are going to be treating HIV and TB with ECHOs, but a major focus now of ECHO is health system strengthening. So some of these ECHOs will be, how do you increase fidelity for the laboratory? What is the case study there? It's not a patient with hepatitis C. It's saying our results of HIV testing have only 96% specificity. That's the case. That's what experts help solve. And they learn from each other. That's how ECHO works. This is ECHO Cameroon, ECHO Kenya, this is Kazakhstan launching ECHO, Tanzania and Uganda. These will be the sites. So my last slide, what makes ECHO work? Team-based care. Task shifting is the idea of making every human being work at the highest level of his human potential. What does that require? In our view, it requires 3 things. Interprofessional consultation, guided practice, and mentor-mentee relationships. I like to say no human being is immune to the beneficial effect of a mentor if these 3 things occur. ECHO is not just a knowledge network. It will fail if it's just a knowledge network. ECHO is primarily a social network too. It produces a community of practice. We have 45 publications on ECHO. They consistently show one thing: ECHO produces joy of work, not just for the spokes, but also for the hubs. And that's primarily what makes ECHO work is relationships, kindness, love, relationship. That's what truly makes ECHO work. We've looked at it and I've thought about it a lot. There's no other way you can make ECHO work. What is the role of technology to reduce the transaction cost of collaboration? Force multiplication is the idea of 10 times. Demonopolizing knowledge, we talked about. Knowledge expansion is one of the key things, and I'm sure you'll hear that from Darren this afternoon. Key principle of ECHO is all teach and everyone learns. It's not specialist teaching in the primary care, because best practice in medicine is not specialized knowledge. It requires the social, cultural, economic, psychological context in which patients live. We heard Soma talk about that. The primary care sites bring that, and there is learning from each other, and everyone has to be a teacher. How does this strengthen the primary care? Through inputs, enables primary care providers to work at the top end of their licensure. Supports training of CHWs, nurses, physicians to work in interprofessional teams. How does it help surface delivery? ECHO brings the right knowledge at the right place at the right time to achieve the right care at the right place. It sets up an effective triage system, so only a minority of patients travel to tertiary centers. And in outcomes, it directly addresses equity gaps, enabling marginalized patients to receive best practice care near their homes in a timely fashion. Achieves improved access to care, higher quality, better outcomes, and lower costs. We have several studies showing this, and I can explain those in the breakout session. Thank you for your attention.